My name is Yasushi Matsuzawa, Kumamoto University and Yokohama City University, Japan. I'm awardee of Pamri Prize. I'm very happy that I could receive the Pamri Prize. I'd like to express my gratitude to Dr. Ogawa, Dr. Sugiyama, Dr. Kimura, and coworkers. I couldn't have achieved this splendid work without them. I also feel great thanks to my wife and son. I'd like to start my presentation now. The title is Digital Assessment of Endothelial Function and Ischemic Heart Disease in Women. Background: non-obstructive coronary artery disease, NOCAD, is more frequently in women than men. The presence of myocardial ischemia in patients without obstructive coronary artery disease, CAD, was demonstrated to be a high-risk state. It's difficult to diagnose NOCAD. NOCAD have shown to be associated with coronary endothelial dysfunction. We used EndoPAT 2000 to assess endothelial function. By fingertip tonometry, hyperemia after ischemia was measured. The data was analyzed automatically by a personal computer. This slide shows practical measurements waveform. After 5 minutes equilibration, the cuff was inflated to 60 mmHg above the systolic blood pressure and then deflated to induce reactive hyperemia. Reactive hyperemia peripheral arterial tonometry RH-PAT index was calculated using this equation. EndoPAT has several advantages: non-invasive, easy to use, automatic, reproducible, NO-dependent, related to cardiovascular risk factors, and could predict cardiovascular events. Improvement of endothelial dysfunction is important to reduce risk of cardiovascular disease. The purpose of this study was to assess the utility of digital RH-PAT in predicting ischemic heart disease, IHD, including obstructive CAD and NOCAD in women. Methods: RH-PAT was measured before cardiac catheterization in 158 stable women scheduled for hospitalization to examine chest pain. RH-PAT studies were performed in the fasting state early morning after more than 3 days discontinuation of vasodilators. NOCAD was diagnosed by angiography with measurements of coronary blood flow CBF and cardiac lactate production during intracoronary acetylcholine provocation test, and the cardiac scintigraphy with stress test. This slide shows the diagnosis flow chart. 68 patients had obstructive CAD. 72 patients were suspected NOCAD. 32 patients were diagnosed as epicardial coronary spasm. 6 patients were diagnosed as microvascular spasm. 34 patients had negative results for acetylcholine provocation test. We examined adenosine coronary flow reserve and stress thallium scintigraphy. 4 patients with abnormal results of these tests were diagnosed as microcirculatory insufficiency. Remaining 30 women were diagnosed as non-ischemic heart disease. We defined that epicardial coronary spasm, microvascular spasm, and microcirculatory insufficiency were NOCAD. We called IHD that includes both obstructive CAD and NOCAD. This table shows baseline clinical characteristics. I'm simply going to summarize this table by saying there was no significant difference between non-IHD and NOCAD group, except family history of CAD. Regarding BNP, high sensitivity CRP, Reynolds risk score, mild to moderate coronary stenosis, and all medications, there was no significant difference between non-IHD and NOCAD group. I'd like to concentrate on these figures, RH-PAT index and IHD in women. The median RH-PAT indexes of each group was 2.2 of non-IHD group, and 1.6 of obstructive CAD and NOCAD group. Surprisingly, IHPAT indexes were same level between obstructive CAD and NOCAD. We evaluated coronary endothelial function by measurements of acetylcholine-induced coronary blood flow increase. Coronary endothelial function decreased in patients with NOCAD. Fingertip IHPAT well correlated with coronary endothelial function. Of particular importance, multiple logistic regression analysis revealed that Reynolds risk score and IHPAT index could identify the IHD independently. We used log analysis to compare the prediction ability. Both Reynolds risk score and IHPAT index had good prediction ability in predicting obstructive CAD. Reynolds risk score was superior to IHPAT. Concerning overall IHD, IHPAT was superior was Reynolds risk score. Regarding NOCAD, only IHPAT could predict among women without obstructive CAD. In summary, endothelial function evaluated by IHPAT was significantly impaired in patients with NOCAD, and such impairments were equivalent to that seen in patients with obstructive CAD. Fingertip IHPAT index correlated significantly with coronary endothelial function, assessed by ACH-induced CVF increase. Reynolds risk score and IHPAT index significantly predicted IHD. IHPAT was particularly superior in predicting NOCAD. Conclusions. Fingertip IHPAT could non-invasively predict the presence of IHD, especially NOCAD, prior to CAG. IHPAT is a potentially useful clinical test and can effectively identify high-risk patients in women with chest pain. That concludes my presentation. Thank you for your attention.